Hi guys, this is the standalone Prezi for the injury rehabilitation course that we do in the first week, of course, here at NZIS PT course. So for this subject, you're going to need a few documents with you to make sure that you are well prepared for the assessment in this here. So I'll show you what they are real quickly here, just on the screen. What you need in front of you while you're watching this recording here is the PT Injury Rehabilitation Test Preparation document, and here you'll see all of the mock questions that we'll be drawing information from the Prezi and putting onto. So this is the testable information that'll come up in the written exam-based assessment that'll get you credit for the course. So keep this thing in front of you, and I'll be referencing to different questions as we go. Other documents you want to have on hand that you can download from the Moodle website or pick up from me here in class is the ACC Injury Management handout here. Get yourself in working order, and we'll be using some of the pages from here to help fill in those mock question forms as well. And then the final document you'll want is a wee case study document on what is concussion from the ACC Sports Smart website. So have that one on hand as well, either on your computer downloaded, or we can print it out or get a paper copy from me here at NZIS. So back to the Prezi itself. We'll open that up and we'll get on with things. So this course is going to cover a number of different injury classifications. It'll also progress on to treatment options for those common injuries that you might come across. And we'll look at some of the referral pathways as well for a personal trainer when you do come across an injury. Hopefully these injuries are coming to you via physios, through the sport that your clients are involved in, that kind of thing, and certainly not injuries that are happening under your watch as a personal trainer. Obviously our main priority when we're training someone is to ensure their safety. But if the worst does happen, it's really important that you know the process of how you should deal with that. I guess in the context of personal training, the most important thing about this course is understanding the different referral pathways that are out there, knowing your boundaries as a fitness professional, what you can do for your client who has an injury, and recognising, I guess, when it's outside of our professional boundary and passing on to the appropriate person who can help that person. Again, ensuring your client's safety and making sure they're back with you sooner rather than later to continue employing your services as a PT. So, we'll crack into things. First, we're going to look at the general injury classifications. These are classifications that have been essentially used by ACC as part of the ACC process, and you'll be aware that if you've ever had an injury and you've had treatment for it, then you get placed on ACC. And that allows you to get covered, I guess, for work and loss of earnings and that kind of stuff as you go forward. So what do they use on these forms to help identify or classify the injuries that you might have? First one is internal versus external injury. Pretty simple classification, really. An internal injury happens under the skin is the easiest way to put it. So an internal injury is an injury to organs, bones, muscles, and other structures found underneath the skin. It's usually caused by a fall or a blow, and usually happens in one instance, if you like. So a traumatic sort of internal abdominal injury, a sprained ankle, affecting the ligaments, getting struck by a cricket ball, breaking a bone in a fall, that kind of thing would be an internal injury. Whereas an external injury is something that occurs to the body's coverings. In this case, you can see a cut would be considered an external injury. And it has an added complication that could arise from the injury, and that is, of course, exposure to the outside bacteria and toxins that are in our environment. So with that in mind, an external injury brings with it added risk in the form of infection, and there'll be some additives to the treatment plan there in the initial stages of the injury to ensure that we keep the injury site as clean and bug-free as possible. Examples of external injuries, you can see it around the bottom here of the slide here: grass burns, superficial cuts, grazes, and those kind of things would fall into that category. So a good point to pause the video at this stage, whip out the mock question sheet here, the injury prep sheet, and you'll see there that question 1, the finding of 2 examples for each of the following injury classifications. So again, internal injury to an injury to a body structure underneath the skin, with a couple of examples, and an external injury being an injury to the skin surface, effectively all the body coverings. Could include nails, hair, that kind of stuff. If you had hair pulled out, for example, would be an external injury, and a couple of common injuries there. Right, so we'll tap back and forth between these 2 documents to make sure we've got our test prep information covered. Second way that we can classify an injury is acute versus chronic. So acute versus chronic type injury. Acute is a traumatic injury that occurs in one instance. So a sprained ankle where you step in a hole or stand on someone's foot is an acute injury. It happened in one instance of traumatic incidents. Sudden stress to the body, a blow, a sprained ankle, a broken bone from impact, that kind of thing. Whereas a chronic injury is defined as an injury occurring to repeated stress over a period of time. So that could be shin splints from running on hard surfaces over time. It could be a stress fracture in the lower back in a cricketer, a bowler who does that repetitive motion over and over, slamming that front foot into the crease line. It could be an occupational overuse type injury from using the computer or working in a factory with a dominant hand or twisting motion or something. So a chronic injury over time, an acute injury is one that occurs in one instance. Back into the mock questions here, and you can see question 2, provide a definition for chronic overuse injury and give one example. So just the chronic injury there and one example that we've seen on the slide. So again, you can go back into the Prezi, you can pause the video at any stage and go back and have a look at those answers there. Another classification for injury is soft versus hard tissue. Pretty easy to distinguish these guys here. Soft tissue injuries are injuries to soft parts of the body. Injuries to muscles, connective tissue such as ligaments, tendons, fascia, that kind of thing. Whereas hard tissue injuries involve bone. And in this case, we'll be separating bone fractures and dislocations. Even though dislocations technically affect the ligaments of a joint, which allows the bones to migrate away from each other, dislocation is classified as a hard tissue injury in the ACC framework. According to ACC, the most common sports injuries that people make claims for are muscle strains, ligament sprains, and bruises, funnily enough. So a lot of people will go into treatment centres, doctors, physios and that with something that they believe may be more than a bruise from an impact situation. They want to check that a bone's not broken, and it comes back the bone's not broken, but there may be severe bruising or even just normal amount of bruising there, and of course it gets recorded on the incident sheet as a bruise. So pretty common. Okay, so we need to know those ones again. If we dip into our questions here and we pause the video, the 3 most common sport injuries according to ACC are bruise, ligament sprain, SP, remember a sprain can only reflect the ligament injury, and then a muscle strain or a muscle tear would be fine as well. So in terms of the hard versus soft tissue injuries, we're going to start with the hard injuries. And the obvious one to start with there is fractures. So what you see on screen there is probably the worst fracture, aside from maybe a head or skull fracture, is the femur, the largest bone in the body there, being snapped and no longer in alignment with each other. And that's a severe and traumatic injury that can take a considerable amount of time to heal. If you're a bit squeamish, you certainly don't want to watch the next video, which is a video of NBA basketball breaking his ankle in a USA trial match. So I'm not going to show it on this video here, but if you wish to look at that kind of thing, you can see it on the full Prezi on the Moodle website. So we'll just skip past that one there. Again, if you're squeamish, you might look away at the odd picture that pops up during this this presentation, but I'll give you some warning, and there's one coming up. So basic classification for fractures can be open or closed. If it's open, the bone is literally protruding from the skin. So there we see one there, and we'll get off that nice and quick for those squeamish people. And then we can classify it by the type of fracture, which is the angle or the cause of the fracture that occurred. Signs of fractures are usually pretty similar. Localized swelling, some bruising is usually there if it's from impact. Very, very sore and tender. And sometimes it's quite obvious that there's a deformity and a restriction of movement there. So this guy here is affectionately known as a dangler, which means the bones have obviously snapped and are no longer in alignment, and unless held in position, that thing is going to dangle around. There's an awful word called crepitus, which is where the ends of broken bones touch each other, and that's a feeling that you, if you haven't experienced, you certainly don't want to experience. So the aim of any fracture, and of course this is outside our professional boundary, your aim is to, if it happens on your watch, is to ensure that we keep the area as still as possible. But the aim of the treatment professionals would be restore anatomical and functional restoration, make sure it's well aligned, and make sure we've got the use of that limb again. We would probably brace or cast it so it heals in a good position, so really important to line it up properly. And then if the bone is displaced and it's unable to be realigned just through manipulation, then it would have to be reduced into place by surgery. A non-complex fracture will usually heal in about 8 to 12 weeks. If there's a shattering, if there's plates and screws and that kind of thing needed to get it back together, then you're talking a longer recovery time than that. Old people typically recover much slower than younger people, and that is because the hormonal levels in younger people that drive bone growth are missing or very much reduced in older people. Here are some types of bone fractures that I want you to be aware of. So we'll run through all of these, but then 5 of them will be pulled out, and you can add them to your mock question list and study those up. So the first one here is on our list. It's called an open displaced fracture, one on the left here. And you can see that it's open because the bone is protruding through the skin, and it's displaced because no parts of the bone are aligned anymore. So it's been displaced from its normal position there. A green stick fracture is also one of the ones that we will be testing about here. This usually occurs in a softer bone. And children would be the typical recipients of this one because their bones are yet to fully densify. So when, just like breaking a green branch, when you're pruning some trees out the back, you're almost never able to snap it in one go. It'll splinter, and a piece of that outside casing, the splinter, simply juts out from the bone here. A comminuted fracture is another that will be on your list of those to study, and you can see here this is a pretty complicated fracture, probably from high impact, and the complication arises from the fragmentation of bone here. So bone is now floating around in the system and needs to be reabsorbed by the blood. That will probably require some plates to hold that in place, some plates and screws, so that we can fill in the missing pieces again of the bone. May also use some bone glue and that kind of stuff to put some of those large fragments back onto the bone. And then the last one on this page is a linear fracture. You can see a straight line fracture down the length of the shaft of the bone here. It's usually going to come about through longitudinal application of force, which is from the top or bottom, and that could be something like jumping from a high place and landing without absorbing too much force. In a finger, it could be a ball right on the end of the finger that causes that. They're the hardest to diagnose. They can often be hairline in nature, but they heal pretty well because obviously there's a lot of good bone tissue surrounding this, and it just needs to fill in this channel here. So that's linear. On this page here, we've got a transverse non-displaced, which is your 5th and final bone that you'll be assessed on in terms of recognizing this. So in the assessment, you'll be shown these pictures, and you'll just have to match the correct name or term to the correct picture of the fracture. So transverse across, non-displaced, it's still in alignment, and again, this is a pretty uncomplicated fracture, which would heal in about that 8 to 12 week period. Oblique non-displaced just shows that the angle of impact was slightly different. You can see that the fracture happened on an oblique angle here. And then we have an interesting one called a spiral fracture, again probably found in a softer bone, and some rotation was evident in that injury mechanism. One that I've heard reported as relatively common is the picking up of a naughty child off the floor by one arm by an angry parent. And that child spins around because their bones are yet to fully densify and their ligaments and tendons are relatively strong. And the bone simply uncoils there, which is obviously a pretty nasty and traumatic injury, which would take some putting back together and some healing. And the last two here, not accessible, but ones that we should be aware of. The Coles fracture, falling on an outstretched arm, is probably the usual one here, where we break the radius off at its base. Most common in old people, so you'll often see older people with a brace on their wrist or something from a slip in a bathroom or something like that, and it simply shunts the shaft away from the epiphyseal end of this radius bone here. Pot fracture, probably aptly named. This one could happen in a pothole, but it's actually named after the person who diagnosed it first. So we've got a pretty violent sort of lateral shift in the ankle here, and which came first is sort of a chicken and egg scenario. Did the ligament snap on the outside here, causing a lateral shift, and did that pop the fibula off the bone, or was there impact on this side that drove the ankle outwards and snapped the fibula off at its base there? So again, maybe a footballer having his plant foot taken out from him after kicking, maybe a runner stepping off an uneven surface or into a hole or something like that. It would have to be a violent amount of force to cause that kind of result. So, as we go back into our mock questions here, question number 4, draw, copy, trace. If you're not much of a drawer like me, each of those sort of situations in here, you just need to draw the bone and the type of crack or fracture that's occurring. So there you go, green stick, comminuted, linear, open displace and transverse non-displace are the only options that will show up that you need to be aware of in the assessment. And then we're back over the page. So other joint injuries that occur that involve bone are the dislocation and the subluxation. So a dislocation is where the adjoining bones are not broken, but they're no longer aligned properly. And in anatomy, we'll talk about the alignment of bones and how ligaments play a huge part in that. So this would indicate ligament damage, where ligaments have become loose or torn, and it's allowed under force that bone to migrate away from its normal resting position. In most simple cases where a fracture hasn't happened, it's a case of popping that back into place. But again, this is well outside of our professional and ethical responsibility. We shouldn't be trying to reduce people's dislocations. There's a high degree of knowledge that's required to do that effectively without causing lasting damage. So dislocation would obviously be popping these people off to the emergency ward if it's a hip or something that makes them immobile, obviously getting an ambulance involved. And you can just see here that the dislocation is a full separation of the two bones there, and the ligaments that would have attached these through this portion here have obviously loosened right off or snapped. Whereas a subluxation, you can see there's a partial alignment still there. So it's almost like a stepped joint where part of the alignment is still present, but it's sort of slipped a little in one direction. It's left a raised sort of portion here at the knuckle. And these can be relatively common in impact type sports. You can often sublux and then pop back in again. Of course, that would put the ligaments again under some strain and stress and make it more likely that that would happen again. So into the mock questions again. We drop down into this box here. If we show a dislocation, it would be two bones that are no longer aligned, and then the subluxation would be two bones where one is partially aligned but is stepped out of place. The fracture, of course, is just a crack through the bone. So you don't need to draw one in there if you don't wish, but in the test it would be noticing the three different types of injury occurring there. There'll be a clear fracture, a subluxation, and a dislocation to label. So that's the hard tissue injury classification. Just finishing off the dislocation subluxation here, you can see that there's usually pretty obvious signs. Something is facing the way it shouldn't, something has moved, a piece of your body, a limb, has moved in a direction that it shouldn't. You may be looking at the back of your ankle instead of the front. When you look down in the front of your foot, you might see your kneecap has moved to the side. And here we can see a knee where the femur has moved away from the tibia considerably and would need to be reduced back into place there. There would obviously be a limit or absence of movement around that joint. The body wouldn't really want to move it without intense pain sort of occurring. And common causes are anything where I guess you've stretched or torn the ligament, and that could happen over a period of time as well, a repeated sprain, and then one massive amount of force that could pop that bone away from the bone that it articulates with. It can also be a congenital issue, so some people are born and continue to develop with shallow or abnormally formed joint surfaces, which means they're prone to having their joints pop out. Preventing it from happening is your best case. So if you know that you've had repetitive dislocations or that you have very loose joints, then you should prepare for that by using protective devices such as wraps, tape, and those kind of things. However, use of tape and braces can sometimes lead to a weaker joint because the tape and the braces are doing the job of the ligaments and the musculature that should be stabilising. So the use of tape and braces in sport and activity, you've got to weigh up the cost-benefit relationship of that, which is that, that might look after you during the actual sport, but you're not going to wear it all the time. So the next time you're down a beach and you hop from rock to rock or you walk on an uneven surface, the likelihood is you've got an even weaker limb or joint, and that could result in you causing an injury away from the sports field. So I guess one way of looking at it is if you have to rely for confidence on a brace or taping, then should you actually be playing the sport is the bigger question. Infants, babies are actually examined for congenital hip dislocation, either at birth or by their midwife, who casually pulls on the leg and sees what sort of resistance there is to pop the hip out of its socket. And if they determine that there's little resistance there, they may put some treatment plans in place to try and deepen those sockets out. And that often includes double casting of the legs with a wee A-frame type setup to try and drive that hip into the socket deeper as the baby's pelvis forms. A dislocation is usually pretty curable. The longer that it's out, probably the longer the treatment and the recovery process is going to be. So you could be looking at anywhere between 2 and 8 weeks, depending on the level of tearing of muscle and surrounding tissue like ligament that could have happened at the same time. So the next wee part of this presentation is going to look at soft tissue injuries, and you can see the topics we're going to be talking through: ligament sprains, muscle sprains and tendon injuries, and we'll also look at a little bit of head injuries as well, like concussion, which of course affects the brain. All common injuries that you'll come across at some point, either in sport alignment or in the PT setting. So the first one we're going to look at is ligament tears or sprains, and sprain can only be used with correct terminology alongside a ligament. So most of you will be familiar with this site, the purpling around the ankle joint here. And the ankle is obviously one of the most sprained joints in the body. Thumbs are pretty common as well, and wrists. So what is a sprain? A sprain is a result of a sudden overstretching of a ligament, which results in the ligament being weakened or torn, usually caused by an abnormal movement outside of the usual movements of the ankle. So a side-to-side type movement is most common at the ankle, or a body part being taken beyond its normal flexible range. So we'll tap into mock questions here. Question 6, define a sprain. So it is a tear or overstretching of a ligament caused by a sudden abnormal movement. There are different grades of ligament tear, and each grade of ligament tear has its own sign, so that's what we'll work through next. But with a ligament injury, and many of you would have had a sprain or particularly an ankle sprain before, some people, after the initial pain sort of settles down, so I think basketball, netball, that kind of thing, and someone goes down in a bit of a screaming heap on the floor and then gets up and tries to walk it off, and then pretty soon, a couple of minutes later, they're back sort of running around, done their shoe up a little bit tighter, and away they go. So that initial pain is quite intense, and then it sort of subsides once it's got you off the ankle. And unless that ankle is then held in a firm position, it's likely that it may heal in the stretch position. What do we mean by stretch position is the ligaments that have been stretched may heal in that lengthened position, which over time would cause a weaker or looser ankle joint. It's also worth noting that if you return to sport with damaged ligaments, the likelihood of you causing a complete rupture of the ligament or a dislocation has just gone through the roof. Usually when you talk to people that have sprained a body part, they've done it far more than one time. So constant repetitive straining is quite usual, and that's because a ligament almost never regains its usual length after being damaged. So it will always effectively have a level of instability around it now. The common sites for this type of injury are the ankle, and as we said, around the thumb and wrist, but also the knee, and the ACL is an ever-increasing injury, particularly in contact and explosive non-contact type sports. So the ACL is found in the knee. The different grades that we'll look through here. So we'll have a look at the picture first. So there's a grade 1. So what I suggest you do in your mock questions here is just draw the ligament portion of that, so just the fibers of the ligaments, and then just list a couple of signs down here, and I'll dictate what those signs are now. So here's the ligament portion that you'd be drawing in. You can see just a few minor tears to some of these ligaments, but it's still in relatively good shape. Okay. So the signs that you look out for in a grade 1 would be some pain. There would definitely be pain there initially, but no increased joint laxity, which means that that joint doesn't have any sloppiness associated with it. It's not moving in a direction that it shouldn't move in. So, for example, in the knee joint, it's not slopping side to side or forward to back, an area that it shouldn't have been pulled on. Grade 2, we would see a partial tearing of the ligament. There's definitely pain when you use it again, and this time there would be an element of increased laxity. But again, outside of your professional role to actually try and diagnose this, leave it to a professional. There's a grade 2, you can see a partial tear, so basically a 50% sort of tear through most of the fibres, but still something intact, which will aid the repair and won't require surgical intervention. Grade 3, however, is a complete tear of the ligament, and if the examiner pulls or pushes the joint, it will slop drastically to one side or the other, as it will be no resistance against that movement if the ligament's no longer there. So, gross instability or looseness is one factor or symptom, and then interestingly, it may or may not be painful, and that really depends what the nerve endings in that ligament are now touching. So, if those ligament nerves or nerve endings are touching against each other or touching against the joint capsule, it may produce some pain. But if they're actually floating in the synovial fluid within the synovial joint, then they're bathed in fluid. They may not essentially transmit signals of pain. So on occasion, you'll see a person who's got a complete tear or rupture hit the deck, get up and try to stand on a limb that can no longer support their weight and would fall over again and not really, or be a bit confused about what's going on. Okay, so a grade 3 tear is a problematic injury now because this thing's not going to graft back together on its own because we have a full rupture, as you can see here. So usually surgical intervention is going to be needed in this case here, unless it's a ligament, for example, that is in a place where the person that the damage was caused on doesn't really need that level of stability. An example of that might be an older person with a lateral ligament in their knee. Unless they're involved in rapid change of direction and that kind of thing, a surgeon might think, well, it's not really worth opening the person up later in life to repair that, when if they stay away from sort of quick lateral movements, it's unlikely they're going to need that ligament to any great degree. So there's the ligament sprains. You can see a wee grade 1 and the grade 3 snap there, and the coloration. Obviously, the coloration here and the swelling is a protective measure, really. The capsule itself, which wraps around the bones and encases all of the key things inside, like the ligaments and so usually has some form of rupture associated with it as well, and there's obviously fluid leaking and blood vessels being broken there as well, and that's what the discoloration is about. Okay, so tendons connect muscles to bone, and you can see here an Achilles tendon or calcaneal tendon with a complete rupture at the base of it there, so it's pretty serious injury going on there too. Tendon injuries are classified as partial or complete ruptures, so either some minor tearing or a full tear. Injury sites are usually the point of least blood supply or the muscle tendon junction, which is where if we look at this one again over here, this would be the muscle tendon junction right here. This is a common place where injury occurs. Tendon is far stronger than the muscle in terms of physical consistency. It's made almost entirely of collagen fibers, and its connection to the bone is very, very secure. So usually it's unlikely that you would tear a tendon in one instance without there being some chronic or inflammatory type disorder that's going on there, so some ongoing injury and pain. So if a tendon is ruptured or torn because it's been structurally weakened by something like tendinitis, or when it's had a huge amount of stress put through it from an unexpected force, the tendon tears, and it doesn't have much blood flow at all, which means it's a very slow healing piece of tissue. A couple of pictures here. Here's one of an older gent who's obviously had either a partial or full rupture of his bicep tendon, so this bicep is sitting not where it should be, and when a surgeon goes in and tries to deal with that complete rupture, this is effectively what he's looking at. How do we put that thing back together effectively? So there's going to be all manner of scar tissue and ongoing problems effectively once you've torn something to that degree. So I guess the key message there is listen to your body. If your tendons are hurting on a regular basis, then that's indicating a problem, and that problem can lead to a weakness, and that weakness can lead to a rupture, which we want to avoid at all costs. Rupture repair is pretty obvious. You need to have surgery, and then it needs to be immobilised while that heals, and the healing time, because of that low blood flow, is often longer than 6 months, 6 to 9 months sometimes. So that's a season ender. Write the rest of the year off, and a long recovery process after the initial healing takes place. Chronic tendon injuries are probably a little bit more common. Sometimes a tendon can become inflamed, where the action of the muscle pulling the tendon becomes irritating and causes an inflammation and the laydown of scar tissue. And if that normal smooth gliding motion of the tendon through the bony crevices that it usually slides through is impaired, then it rubs against the sides of those bony crevices and more inflammation occurs and becomes painful. This is called tendinitis, and tendinitis literally means inflammation of a tendon. And you see we star next to tendinitis there, and that is because this word is somewhat being phased out. More recent research suggests that a lot of the injuries we associate with tendinitis are actually not inflammation based at all. Tendinopathy or tendinosis are now terms that are often used by practitioners these days, and we'll talk a wee bit about them very soon. So, inflammation of a tendon, you can see here, that is not a healthy looking tendon that we see here. This is a lot of white scar tissue sort of in amongst here. You can see it's been stitched together to try and hold it together, but that is not a healthy looking tendon compared to this nice white smooth tendon that's going on over here. So chronic tendon injuries can occur as a result of injury and then not allowing it to heal properly before getting back into activity. Overuse, so just using a body part too much and putting it under chronic stress. Age, as the tendon loses its elasticity and we continue to try and get the most, I guess, out of it. We're playing into our late years and not hanging up the boots, so to speak. Can also be seen in systemic diseases such as rheumatoid arthritis and diabetes in greater amounts as well. Can occur in any tendon, but the most commonly affected sites are the shoulder, particularly around the rotator cuff, the wrist, the heel and the elbow, which are all high use areas, and that's why they would start to complain after a period of time. So let's look at the separation between tendinitis and this new tendinosis or tendinopathy. The original thinking was that the tendon itself, the collagen fibers that made up the tendon, were swelling from within, so intra fluid collection. So each individual collagen fiber was getting thicker, and that was leading to swelling of the entire tendon, and it might now rub on the bone that it glides against or something like that. And the theory was that if that happened, then you treat it like any other inflammation disorder, and that's usually using cold as the mechanism for getting it down, or anti-inflammatories. The problem was that the research that was put into the use of anti-inflammatory medications and ice treatment were actually pretty ineffective. So there was very limited evidence that A, the pain subsided, and B, the use improved of those areas, which got researchers thinking, well, if that doesn't work, what are the other therapeutic modalities? And if that doesn't work, and it is a normal approach to dealing with inflammation, then maybe it's not inflammation. So a new school of thought started. And that school of thought actually started to think that rather than tendon fibers individually being inflamed, was that fluid was making its way in between the collagen fibers. So a good way to think about it would be a climbing rope. So you're about to climb up a crevice or a hillside or a cliff on a climbing rope. You check that rope, and what you're looking for is that that rope is tightly woven. There are no spaces between the little rope fibers that make up the entire rope. And the tendon is much the same. So if you look at a tendon and there was fluid separating those fibers, and there were larger gaps appearing between the individual collagen fibers, and that would lead to a weakening and a swelling-like sign, if you like, with the tendon thickening. So just like a rope that is fraying, you wouldn't want to hang your body weight off it at 80 metres off the ground. Similarly, you wouldn't want to put a huge amount of force through a tendon that has a lot of fluid separating the fibres. Other methods that have been used for treating this chronic tendon injury are things like steroid injections, which again are potent anti-inflammatory agents. So they act on the entire joint space rather than just the tendon. And you actually should never have them directly into the tendon anymore, because they can cause degradation of the tendon over time as well. Physical therapy, friction type massage, lengthening, and all that kind of stuff would be applied as well. But it's really working within the pain barrier that the client has. So when you're working with a client who has tendon and ongoing tendon issues, it's about finding time in the day where it's better to work, and then helping them with recovery strategies that limits the amount of pain that they feel after. And using a pain scale is a great way of doing that, getting them to rate the pain scale in those areas as they do different exercises and as they arrive for the session of the day. And it could dictate what you do with them. Okay, so muscle. And what we'll do is we'll finish this muscle one, and then we'll end this session. So this will be the first of a two-part session, just so you're not stuck here for too long going through stuff. So before we move on to the muscle, though, we'll just click back into this one here where it says define tendinitis, and the definition of tendinitis would be inflammation of a tendon. And then under number 9 here, more recent research suggests tendinitis should be called tendinopathy or tendinosis. Why? And the reasoning there is it's now thought not to be inflammation based. It's thought that fluid separates the collagen fibers in the tendon, weakening it. Two treatment methods, therefore, for dealing with tendinosis would not be ice, because that would be suggesting it's inflammatory based. It would actually be the opposite, which is heat treatment. So drawing blood flow to the area and then allowing that blood flow to take off and take with it some of the excess fluid. So we heat a tendon that is stiff and achy, and then that prepares it for use. And then after we've used it, we may look at an ice protocol there to reduce any residual inflammation that might have occurred through exercise. The other thing we could do down the track would be a cortisol injection. We could also use pain medication and lengthening therapeutic modalities such as massage and rollering and all those kind of things, foam rollering, that kind of stuff. So any two of those would be fine. Okay, so just to finish off this little bit here, we'll look at muscles. There's nothing on your assessment sheet to do with muscle tear, but it's worth knowing obviously how to treat it, because this is something that could crop up. The words we usually use around them are strain, pull, or tear, in reference to a muscle, and that indicates that the actual fibres of the muscle are tearing. Now, there's a lot of blood flow within a muscle, so accompanied with any muscle strain is going to be an element of internal bleeding, which we need to stop before the healing process can start. So that may or may not be visible bleeding. So it may not be bleeding that we see under the skin surface in bruise form, but in grade 3 situations, it definitely can be, and I'll show you a picture of a good grade 3 tear soon. So often a muscle will tear when the muscle suddenly and powerfully contracts, or when a muscle stretches beyond its usual capabilities. And we do have nervous system receptors whose whole job it is to prevent that happening, but sometimes we put ourselves in positions, particularly in contact and those kind of things, where we get pushed far beyond our means, and that would be called an acute strain. You can also get chronic strains over time, where probably using incorrect technique over and over again could lead to a chronic strain in a lower back or hamstring. Strain are usually the most common there. Strains are pretty easy to identify. There's usually pain, and not only pain when you use it, which is very sharp, but a throbbing sort of pain that's there even at rest. A lot of sensory receptors found within a muscle, so they give you constant updates on how it's doing. There'll be some swelling, probably some bruising or at least redness, and if there's open cuts as well, we have to consider that infection risk too. When you use it, there will be a very sharp and debilitating pain, which will prevent your brain from wanting to use that muscle at all. So we'll look for compensatory mechanisms to try and get ourselves around or manipulate our environment. Grades again, same as the ligament ones for the sprains. So grade 1 is mild, grade 2 moderate, and grade 3 severe. Grade 1, localized pain and stiffness will be the symptoms, and it will last a couple of days, and there'll be no loss of strength apparent. You'd still use it. DOMS, delayed onset of muscle fatigue, would be an example of a mild strain, the sort of damage you do after a hard bout of exercise. That makes you a little bit tender and sore tomorrow, and usually after a couple of days peaks and disappears. That sort of pain. So we're talking some minor tearing of the muscular fibres there. Grade 2, which is probably the one that would set you back a few weeks. That's one that's pretty common when the hemi goes and you know it's gone, and you pull up straight away. You can't continue with a grade 2. Partial muscle tear, extensive pain. Whenever you try and use it, the swelling would come up, and the pain would last probably between 1 and 3 weeks, depending on its severity there. And you can see there's some serious sort of damage going on the fibres there, this quad muscle. And then grade 3 is a very severe one, where the muscle's literally torn apart. Maybe torn away from the bone. There would probably be significant bleeding that would make its way to the skin. It would be obvious on the surface that something bad's happened. Muscle may not function at all. Will probably need surgical repair, stitching back together and that kind of thing, and will probably have long-term complications as a result of that. Again, most common at the muscle-tendon junction, which typically seems to be the weakest part of the muscle. And there we go, ripped apart. So a couple of pics there. There's a nice looking grade 3 hemi injury. So no impact has occurred there. That's a hemi that's gone and has bled pretty profusely into the space between the muscle and the skin. And on the right hand side here we see a calf muscle tear. It should look like this. Nice clear dark shaded muscle here, and we see this white tear that's occurred here. So literally like taking a piece of steak and just ripping a piece off. And that's going to cause significant trauma to that muscle, and obviously it's going to take a fair while to have any trust in that muscle again. So we'll finish on these risk factors. These are things that will make it more likely for you to get a ligament sprain, a muscle sprain, a strain, and those kind of soft tissue injuries here. These are the 4 key things. Number 1 is poor conditioning. You've got to ask yourself, are you involved in a level of activity that is appropriate for your level of conditioning? So a lot of people play sport to get fit, which is a recipe for disaster. You need to get fit to play sport. You need to start working on your baseline fitness, give your soft tissue a chance to sort of condition itself towards the the high intensity play that is going to take place down the track. And this is where pre-season and off-season training comes in. Same in the gym, just walking into the gym and putting heavy weight on and going for it. Having a lack of condition, your muscles, your tendons, your ligaments are not prepared, and you're more likely to sustain injury as a result. Poor technique, whether it be in sport, whether it be in the gym, and gym is probably a good one to talk about here. Going in and putting some weight on a deadlift bar and hinging completely off your back with poor technique, and bang, the back extensors go. So technique's really important, and of course we can use people like yourselves once you're qualified to get that technical information and cues off. Fatigue may relate to some of you guys, so I'm a pretty firm believer that most of us are not at risk of over-fatigue, over-training. When you look at what some people do, as long as you care for your body, as long as you give it some recovery, some fuel, and the right sort of nutrients and rest that it needs, you can do a hell of a lot of exercise without falling into an overtraining category. So overtraining is really a combination of doing a lot of exercise but not actually fueling well for it and not recovering well from that exercise before the next bout of exercise. And that really comes down to a little bit of ignorance. So knowing the protocols around fueling, recovery, and that kind of thing means that, and of course programming, making sure that you're doing activities that are relevant to your current level of condition, should avoid fatigue factors. But the reality is tired muscles are more likely to succumb to forces that could stress a joint or overextend the muscle. And then probably the biggest one here is no matter how conditioned we are, if we go straight into vigorous physical activity without any sort of warm-up, then you're putting yourself at risk of a soft tissue injury. So, just to finish off this little segment here, guys, back into the notes over here. Identify 3 risk factors contributing to ligament sprains, I'll just get rid of that, and muscle strains. 3 risk factors contributing to ligament sprains and muscle strains. That is poor conditioning, improper technique, lack of a warm-up would be another one, and as we saw over here, fatigue is probably the 4th one that would stick in there. So pretty common sense type stuff. Cool. So thanks very much for listening. We've made a good start on the injury recovery stuff. Good time for a break now. If you're feeling fresh and you just want to kick on, you can access video number 2. It'll be around about the same length. We'll cover all the other aspects that we need to cover in this subject. Thanks for listening in. Catch you up.